speaking of blood pressure, we've got the world-renowned Dr. Wiederman this is the second time around that we were able to have a conversation with you from GRMC. Your healthcare partners is brought to you by GRMC, where patients are partners. Hello, Dr. Wiederman. How are you?
Very good.
Good to see you again.
Nice to be here.
You look great. You look tanned.
I am profiting from the pleasures of living here.
Yeah, and away from New York and the snow, or the East Coast and the snow and all of the yucky stuff that's happening over there.
Yep.
Yeah, sun is good. Now, do you work out? I have to ask the cardiologist if he do you work out? Is that what's your regimen?
Well, I try to do what I would say is the bare minimum for everybody, which really is just 30 minutes of aerobic exercise a day, 5 days a week. If you can do that, actually, you reduce your risk of having a heart attack by about 70%. So all you got to do is swim for 30 minutes a day. Even 15 in the morning and 15 in the evening does it. Okay. And I try to do about 30 minutes a day, 5 days a week of aerobic exercise. That's about it.
Okay. And even with your schedule, because people will use that. Like I don't have 30 minutes. I don't. But you're a busy doctor. You must have 30 minutes somewhere or you make it.
It's like really not that hard. Yeah. 15 minutes on a treadmill in the morning and 15 minutes in the evening, or go for a 30-minute swim in the evening and actually swim. Don't float.
Yeah. Okay. Actually move your arms.
It's just not that hard.
Well, it's like budgeting for your power bill. You know what I mean? You have to pay the bill every month. It's the same thing.
Oh,
right?
I agree.
Yeah. So it's kind of like that, investing, in your health like that.
I mean, all the things that we do to try to prevent disease, to know that by exercising 30 minutes, 5 days a week, you reduce your chance of having a heart attack or a stroke by about 70%. That's a pretty good return for investment. It's really not that much to do 15 minutes twice a day.
Okay. What do you eat then?
I will be honest with you. I eat anything I want to eat. Yeah. And I am very fond of Chamorro cooking.
Oh, okay. So, Chamorro. Don't call us Chamorrons because it sounds bad.
Okay, sorry.
Chamorro. No, it's okay.
I'm still
learning.
We're
good.
I'm still learning.
That's all right. At least you got there. You like Chamorro food.
I like all kinds of food, but I also do have high cholesterol. So I take a statin every day. And with a statin and some exercise, my cholesterol is great. And that does allow me to be a little bit more indulgent with how much barbecue I eat.
Okay, because I just ate 3 pieces of bacon, which I have not had in about 6 months. But I got a taste for bacon this morning, and I went to the place and I said, give me extra crispy 3 pieces of bacon. And it was the best thing I've ever eaten. So that means I do have to pump up this afternoon.
Yes, you have to work it off.
Okay, so you got to work it out. All right. And along with this, if you're looking at us on Fox 6, is Jose Mundo.
Oh, hi.
Hi, how are you? Moving closer to the microphone. See, he's an old pro at this. He knows how to moving just like the doc does. How are you, Jose?
A whole lot better.
Yeah? I'm assuming you're the patient.
Yes, ma'am. Yes,
all right.
yes.
We've never had the direct relationship placed before us here. So I'm going to ask if you don't mind to tell your story.
Yeah, it was pretty complex when I first had my heart attack. I had it 3 times. So the first one was over in October. I think it was like October 31st. Had it over at GMH. So the docs were wondering where were they going to put me next. So my mom's like, "Hey, you want to go to PI?" I was like, "PI?" I said, "Why not here?" So me and my sister, we all talked about it. So they went back to my doctor, Dr. Goda Fernandez. So she's been a big help. And she had me referred to Dr. Joseph Wiederman right here, which he's a really good doctor in that. With the operation it went smoothly. It was accurate precision that he did on my stent of my heart. So I didn't feel any complications or any irritation. And I didn't know. It was just a short minute of time. It felt like it was only 30 minutes when I was in there. Then bam, it came out. I was fine. And I was still awake during the operation.
Oh, okay.
So, yeah.
That's a pretty easy procedure then, I'm assuming. Is it a pretty simple procedure?
Well, it kind of depends on where the blockages are and how many there are. In Mr. Mundo's case, he was, in a way, fortunate in that he had a focal, that is a short area of 90% blockage in the left anterior descending, which is the artery that supplies the front wall of the heart. But that was his only area of blockage, so that could be fixed with one stent. And yes, it went smoothly and it didn't take that long. It'll vary from person to person depending how many things need to be fixed.
How did you feel? I mean, what were the symptoms that brought you to the hospital to begin with?
Weak on my left arm, and then shortness of breath.
That's the telltale.
Yep.
Well, that's one of the symptoms.
Yeah.
Again, chest pain is the most common symptom, but sometimes people present with shortness of breath, and that's what we call an anginal equivalent. That is, it is pretty much the same as chest pain. And certainly, if we go through Mr. Mundo's story, he actually came in, the first time he came in to GMH with very dramatic EKG changes, consistent with an acute heart attack, and they gave him a drug to dissolve the clot, which is the final step in causing a heart attack. And the drug worked in terms of stopping the heart attack, but it doesn't actually treat the underlying blockages. So the recommended course of action, if you get this drug for a heart attack, that sort of stops the process but doesn't fix the problem. What we recommend is that you have a catheterization within 24 hours to fix the underlying disease so that it doesn't happen again. Unfortunately, in Mr. Mundo's case, instead of having a catheterization, he was sent home, and he came back in several weeks later with a recurrent event. So what guidelines suggest is have the catheterization before you go home, because the clot just fixes the last final step. It dissolves the clot, but often it'll leave a 90% blockage underneath, which could, as it did in his case, cause another heart attack pretty soon. So what I would like to ask people all over the island to do is, if people come in with a heart attack and you give them a successful clot-busting drug, transfer the patient to me the next day so that I can fix the problem.
Is that the window, the 3 weeks that he left the hospital till he had to come back again? Is that the window for the drug to be effective?
Well, no, the drug only works for 24 hours.
Oh.
So the rest of it is random luck. He could have had that event 2 days later, 3 weeks later, a month later. It's like having a sword hanging over your head.
Yeah.
Because really, again, blockages develop over years. They develop until they're about 80 or 90% blocked. And then when they get that blocked, the blood flow is sluggish. So there's a tendency for a blood clot to form. That changes the blockage from 90% to 100% in minutes. And then the drug they give you, the clot buster, dissolves that clot, but it leaves you with a 90% blockage. So that's why we, again, the American Heart Association guidelines would recommend catheterization as soon as possible.
Okay. So he comes back with the same symptoms. Is this when did they give the same medicine, the clot buster? Is that buster, or they did it again?
They did, but on the second occasion, they actually transferred him over, and we were able to fix the problem so that it won't happen again.
Right. Wow. You had a bunch of angels watching you on that one. Yeah.
Thank God he sent me to Dr. Witterman. He's like a saving angel here.
Yeah, I that's what I hear. That's why I said he's world renowned like that. He's a savior. Yeah. Clearly GRMC had the expertise, number one, because that could have been avoided the very first time, and then second of all, what kind of equipment do you have up there in the suite that lends to that kind of care? Well,
so in order to do coronary intervention, you need the equipment that allows you to take pictures of the arteries, which are basically just catheters, hollow plastic tubes. But then you need a variety of different balloons and stents in multiple sizes to be able to treat blockages in vessels that have different diameters and different lengths. And most recently, GRMC has purchased more advanced equipment, including rotational atherectomy, which is essentially a tiny diamond-studded drill that we use to treat lesions that are very calcified, where balloons won't expand. We now also have a device called fractional flow reserve, which is a wire that measures actual blood flow. So if a blockage is equivocal, like we're not sure if it's really bad enough to fix, which usually is the borderline 70% lesion, this wire will allow us to determine whether it's significant enough to fix or not. And we also have a device called intravascular ultrasound, which allows us to do ultrasound imaging of the artery from the inside to make sure that our stents are fully deployed and in the correct position. So we now have more sophisticated equipment that we got compared to when I first got here, and that's basically to increase the range of procedures we can do, make it safer, and make it more effective. So the hospital has been very supportive in building essentially a state-of-the-art interventional program.
Now, do you have to keep up with the technology, or is it OJT as the technology is born, or is this the stuff that you're telling the hospital, I've already been trained in this, we need to buy this stuff?
Correct. This is stuff that, some of this equipment has been developed over the last 10 years, but as it gets incorporated into the armamentarium, it becomes kind of indispensable to do the right thing during procedures. So I tell the hospital, you've got the basics. Now that we have the basics established, we need the more fancy stuff, because probably around 15 or 20% need more sophisticated equipment when we do interventions, and the hospital has been very supportive.
So I read
all the time.
You have the basic stuff, so you're just buying components, basically. Are you buying elements that will for the overall?
You buy newer devices that allow you to take care of more complex niches. For example, calcified disease, which is why we need something like rotational atherectomy, is extremely common in people who are on dialysis. And as you know, we have a large population of renal failure patients on Guam. So for us, that's a big proportion of the population. So we're trying to basically offer a full service interventional cardiology the way you would on the mainland.
Well, Jose, how have you been since now? When was this procedure, the last procedure that has saved your life? When was that? How long ago was that?
If I'm correct, November 2.
In November, just this past November?
Yes.
Oh, okay.
And then he just released me the next day.
Oh.
And I feel great. I feel brand new.
Did you know that? What were was this something that you've had for a long time, or how did you know? You just recently developed it.
The first heart attack I had was 2 years ago. So I just kind of brushed it off. I thought it was something normal, not so seriously. But when I had that one, it was only 30 minutes of chest pain, chest pain, and then I was having a hard time breathing again. So I was like, man, I think it's my sugar. I gotta stop. And especially with this frittata, they call it diniguan. You eat all those habits that you've been brought up, especially with our culture. But it's up to us to look at those things
and change them.
Change the way.
So you
eat.
were a smoker, and you were eating high-fat foods, high-cholesterol foods, and these are all contributing factors.
Yes.
It's clearly a lifestyle.
It is a lifestyle change. Now, in terms of food and cholesterol, there is something we can do about that. We certainly want you to eat better, but the cholesterol-lowering drugs are extremely effective at taking care of that problem if you take your medications. The smoking is a disaster. There's nothing we can do to fix it. There's no drug that fights it. It increases the chances of developing coronary disease fourfold. It also augments the chances of spasm inside the arteries. I mean, of all the vices there are, from my perspective as a cardiologist, that's the one that really has to be cut out, because we can't fight its effects any other way. You really just have to stop.
So was that a cold turkey stop? Did you have to?
Yeah, cold turkey, yes. It was a battle. But yeah, I feel a lot better, because with his big help, man, it made me see things in a different view. So I took that one seriously, so I don't smoke anymore.
In the scope, well, you have to have a willing patient. You have to have somebody who's cooperating with the procedures. You have with your prognosis, your diagnosis.
Yeah, well, having a heart attack does tend to focus the mind a little bit. It's kind of an incentive, and there are things you can do to stop smoking. There's certainly nicotine patches. There are a number of drugs like Wellbutrin, which can decrease the desire to smoke. But all of those treatments are only effective if the patient is motivated.
It's all about the willpower. And like you said, there's no drug for that. There's nothing you can do for willpower. There are cessation programs, and you can go through therapy. You can do all that, but it boils down to willpower. And like you said, heart attacks have a way of changing your mind about things or tweaking things. How are you liking the gig here at GRMC?
Oh, I really love it. I mean, for one thing, one has the sense here, which is not true everywhere in the U.S., obviously, of being really needed. I'm very busy. There's really, apart from some outpatient stuff, there's no one else doing this kind of thing on Guam. So there's a big unserved population. and the hospital has been very supportive in terms of getting me the equipment that I need so that the procedure is safe. And I feel like I'm having an important impact on the health of the population. Plus, I mean, in all honesty, it's a wonderful place to live. The people are super nice. I'm happy being here.
Yeah. But unfortunately, in your profession, you know, you're seeing people with heart disease, which is, you know, although it's great that you have all of these great resources, and the hospital has been cooperative in seeing your vision for the suite. It is kind of a, I don't know, a conflict maybe. The more patients you see, the more you can justify buying more equipment. But then we're also talking about people's lifestyles and diseases and things that cut their life short.
Well, there's no question that what I'm doing is putting out fires, and it would be nicer if the fires didn't start. Now, obviously, that requires a lot of education. You need to change lifestyle habits. You know, you need to improve people's desire to exercise. There are things that could be done, starting at an early age, so with a lot of education as well, to reduce the number of cases that I do, which is the eventual goal. Yeah. No question about it.
You know what? I also see, but here's interesting stuff. Like, I've seen people who clearly have a lifestyle that is not conducive to, you know, their health. Maybe they appear to be very overweight, and you see the foods that they're consuming, yet that's not why they're dying. You know, how do you explain, you know, obesity and bad eating habits with a person with zero heart problems?
Right. So the concept that science 100% explains every event is just not true. We can say that if you have the following habits and the following cholesterol, you know, you have an 80 or 85% chance of developing heart disease. But there's no question that 15% of people who should in some way get heart disease don't. I mean, there's an element of luck in this as well, you know.
What about those who don't have heart disease and have a really good lifestyle who die? Athletes.
You know, the thing about that is you hear about that because it's so dramatic, but it's actually very rare. You tend to hear about it more than statistically it actually matters. I mean, most people who exercise regularly and eat well stay healthy. All right. They should be more worried about walking in front of a bus than about having heart disease.
Right.
But the ones you hear about because they're so rare that they're good news stories. It's really pretty exceptional that happens.
Okay. But generally speaking, you know, these are the habits that will lead to this.
Yes. Absolutely. And all we can make is an argument saying statistically this is what's likely to happen. We can't compensate for either luck or God's will in these things.
Yeah. Okay. Interventional cardiologist. That's exactly what we were just talking about. Everything that you can do to prevent having a heart attack. But if you already are prone, is it hereditary to have heart disease?
Well, there is a hereditary component, but usually the hereditary component either has to do with a hereditary tendency towards diabetes or a hereditary inability to metabolize cholesterol well, resulting in high cholesterol. So usually if you control the actual risk factors, you can negate the family history because the family history usually just represents untreated risk factors. So it's not like karma. It's not destiny. You can fight against it. All you need to do is get your cholesterol and other risk factors under control.
Okay, this is why we wear the headphones. There is a call, and his name is Jose. He wants to say something to you, Doc. Hi, good morning, Jose.
Hi, good morning.
Good morning.
I was a patient down at JMRC. It was February, and they couldn't. I guess there was no cardiologist at that time. So, and I was sent home twice.
Okay.
And
February. Okay. Turn up here. This is your voice.
Yeah.
Sorry.
And I want to know what.
Can you hear now, Doctor?
Now
okay,
I can hear.
Jose,
I didn't hear. Yeah.
Okay, Jose just said that he went to GRMC back in February, and they didn't have a
February. Yes.
Of last year. Were you here at the time? He said that they were sent home because they didn't have a cardiologist or a specialist for your specific condition.
Yeah, what they did is I was diagnosed with heart failure. They said there's water in my lungs and everything. But what they did is they sent me home.
So this was in February of 2017.
I've been back and forth twice.
Yeah, I didn't get here until August, so that was before I got here, yeah.
Yeah, I want to make an appointment and see you.
I have clinic once a week.
I hate traveling.
Okay.
I've been going back and forth to St. Luke's, but I want to.
Okay.
We'll be happy to see you.
All right, Jose. Hang on one second, doctor. What are your clinic hours?
Every Wednesday afternoon.
Okay, so tomorrow, like after 12.
Yeah.
In other words,
they have to call and make an appointment, but I'm happy to see you.
645-5500, Jose.
Okay.
And well, you might know that number. He has clinic clinic tomorrow afternoon, so you might want to call and see if you can't get in soon enough. But it's only.
I'm going to be here for a while, maybe longer.
I would glad to meet you and my daughter. And we've been going through a lot of stuff like this in the island.
Oh, I'm so sorry, Jose.
A friend of mine passed away because we don't have facility for it.
You come see me as soon as you can.
Call them now, Jose. 645.
Yeah, because I had the bypass already in St. Luke's. I just want to have a permanent doctor here in case of emergency. We know who to look up to.
Yeah. Establish the relationship. You've already made the first step.
Okay.
Thanks, Jose.
Thank you.
How emotional can that be? To not have the care when you know it's available across the pond, but you can't get it in your own backyard.
I think it's incredibly frustrating, and as a family crisis, I can't imagine anything worse than knowing that you have a problem that's fixable and it can't be fixed here. And I've seen the patients who do need bypass surgery and are trying to get transferred off island, and it's quite the project, and it can take a long time. So another thing we're working on actually is getting a bypass surgery program for Guam. That's going to take a little longer, but that's on the agenda as well.
You deal with intervention, and so if somebody calls and they make an appointment, could you test them to find out what their bloodlines look like?
Well, we could do genetic testing. It doesn't really, except for very rare diseases, it's not really that important at this point. It might have been important when they were young in terms of deciding how to treat them. But in older patients, what really matters is whether they're symptomatic, getting them a stress test to see if there's something that needs to be fixed, and getting the things fixed as soon as possible and not delaying, because the delay is what leads to the heart attacks.
Yeah. Is it possible that whenever I talk to you about symptoms that they all start happening? What is that, psychosomatic or something? It's like suddenly my arms are tingling, and I don't know what it is, why that happens sometime. But anyway, I appreciate you that time that you've come in twice already. Thank you for
my pleasure
being part of our program. And Jose, I'm so glad that you're in good order now, and at least you have an established relationship with the doctor.
Oh, yes.
I'm glad. I'm glad for you. I hope you live long. I hope you don't smoke anymore either.
Oh, no. I totally quit.
Well, that's what we do every Tuesday. Your healthcare partner is brought to you by GRMC, where patients are partners.